Winter's coming. It's cold and miserable for everyone, but especially those with COPD.
So here's a simple guide to managing COPD exacerbation. 3 key factors that I always check in COPD patients. Number 1 is their functional status. What is their exercise tolerance? Their dyspnea score. How many COPD exacerbations or hospital admissions have they had in the past year? Objective data. Do ABGs show chronic type 2 respiratory failure, defined as a high PCO2 and a high bicarbonate to compensate? Do a CT show severe emphysema or an echo show pulmonary hypertension? Is there an FEV1 value, percentage of their predicted? Number 3, treatment. Are they on home nebulizers, home NIV, LTOT, or are they on high dose directives for carpulmonale? These key factors determine the severity of COPD, particularly useful when you're escalating to the respiratory registrar. Now here are 5 simple steps to managing an acute COPD exacerbation. Firstly, controlled oxygen. Regardless of the severity of COPD, always give oxygen with a target saturation of 88 to 92%. Number 2 is nebulizers. Back-to-back nebulizers with salbutamol and ipratropium. Number 3 is antibiotic. And number 4 is steroid. And importantly, number 5, ABG. Do an ABG on presentation around 15 minutes after the first round of nebulizers and treatment and around about half an hour later. Now at 15 minutes or half an hour, if the ABG shows persistent respiratory acidosis, the pH less than 7.35, or if the patient does not clinically improve, i.e. they're still drowsy, tired, or having intermittent twitches or COPD flap, then escalate to the respiratory registrar because they may need high care for NIV support. Now here are some key important points. Escalate early to the respiratory registrar. Even if the ABG is improving, if the patient is not improving, escalate early. Always look for any underlying trigger. Is there an underlying pneumonia, PE, pneumothorax, carpulmonale, or an ischemic event? The 3 main contraindications for NIV is a low GCS, lower than 9. They won't tolerate it. Upper airway obstructions, excessive secretions, or recent surgery. Or if the pH is less than 7.2, evidence suggests that these patients may not do well on NIV and may need to go to intubation if it is appropriate. Type 2 respiratory failure can occur in other respiratory conditions such as OSA, OHS, or severe neuromuscular conditions. Remember, oxygen is a controlled drug therapy. Over-oxygenation kills. If the patient has been on oxygen, they are getting increasingly tired, they are showing signs of twitching or getting drowsy, then titrate downwards and do it early because you may be saving their life. Now, I hope you found this helpful. Lots of exacerbations of COPD in winter, but hope this helps you and don't forget to subscribe.